it's been great to kind of really bring all of our community together to solve a shared problem that we have. So I am so appreciative of you all participating today. What kind of prompted this is COVID really just messing everything up, making a difficult problem more difficult. And what we were hearing was, healthcare and education are both industries that are resource constrained in the best of times, and COVID really kind of shone a light on where our challenges are and where our opportunities are, and also made things harder, made kind of resources even more constrained. And so, the unemployment rate vacillating drastically over the last 9 months or so, really wanting to make sure that healthcare and education could get together and share kind of what is the reality of today, because it's changing month over month. What is education experiencing when it comes to specifically to educating our healthcare, future healthcare workforce? What is healthcare experiencing, particularly, with our workforce needs? And how can we identify some of those challenges and solutions to those challenges together, so that we can make sure folks have opportunity for great jobs, and make sure that our patients have amazing care providers in the future. Did I cover everything, Lindsay? Is there anything else?
I think you did, Kim. And if not, of course, we'll lean on DJ3 from HealthPoint to fill in the blanks. DJ, do you want to give a few words of why this and the purpose for today?
So first and foremost, thank you all so very much for coming. Yay! Woo! You rock! We know you're busy. We know you're tired of Zoom meetings. We know you're tired of just this endless piling on of stuff. But the realities are, in this given situation, COVID has really created a perfect storm for us. As we look at the reality of healthcare, we're struggling, right? Because people aren't coming to the doctor. But at some point, we're going to get a vaccine. At some point, people are going to start coming back to the doctor, and we're going to need to be able to provide that incredible patient care. And if we don't start to prepare for that today, we won't be ready when the time comes. So this session is really about us coming together as partners, not as opposites, not as one side better than the other side, but really coming together as partners to be able to strategize about how do we continue to create a pipeline of talented, caring, skilled individuals to help fill our needs into the future. So we need you. We need your ideas. We need your energy. We need your passion. We need all of that. So welcome to the party. Please get involved. We need to hear your voices. We need you to advocate. We really need you to share your view. So as we go through this day, please don't feel like, oh, I'm not a subject matter expert, so I can't contribute. I don't have a lot of deep knowledge, so I can't contribute. All voices matter, all opinions matter, and we need all of you together. So again, thank you for coming. Thank you for being part of this, and let's get this party started.
Thank you, DJ3. I knew you'd fill in the gaps there. So let's get this party started. We are going to start off. Are you ready? With data. What better party?
So exciting.
So Liesl, if you can switch to the next slide. Now, we understand you might have to squint a bit. Some of you may be in full screen mode. Some of you may have fancy multiple monitors, and you can put this up there. But for the rest of us, we might have to squint. But here's what we wanted to do. We wanted to just give a quick snapshot for King County. Okay, so it's not all inclusive. It really is just focused on King County, and this is based on actual job postings for healthcare in King County. And so what you can see is unique postings from January of this year to September of this year. So unfortunately, we can't get the data, but we do number data. And what we know is that there were 5,643 unique job postings, job openings advertised online for registered nurses in the King County area. So you can go down the list and see the very top 7 is what we've put on this slide. Registered nurses, home health and personal care aides, speech language pathologists. It's the only one that has actually had an increase. You'll see the percent change in the next column, right? And all of this, right? At the same time, they still are the top 7 most in-demand jobs. So that's what we're going for here. So medical and health services managers, medical assistants, nurse assistants, and then LPNs and LVNs. So let's keep going. If you can switch over, Liesl, then to our next. So this is really where you might have to squint more, because this then is 8 through 20. We wanted to just really give you the first 7, because those are the ones that are sort of above the 1,000 range, and these ones fall below the current postings under 1,000, but still in the top 20. So this is where you'll find medical secretaries and administrative assistants, clinical counseling, psychologists, family medicine physicians. You'll get into a number of different breakdowns of types of physicians. You'll get into physical therapists and dental assistants. We're getting into the under 500 active, right, current postings, again, job openings in King County, when you get into mental health and substance abuse social workers, technicians, other therapists, etc. So this really is just a snapshot. And again, this is not magic data. It's pulled from MZ, a pretty common source of job posting data that's used around the country and here. And of course, not all data is perfect, but that I think at least gives us a snapshot of the current postings at the highest level here in King County for healthcare. So with that, what we'd like to do is actually hear some responses and commentary on that data, but really this is an opportunity to dig a lot deeper into individual organizations. So we've teed up purposely 3 different angles of this data. Obviously, Swedish Hospital, the big hospital setting. We also have Angie Graves joining us from Aegis Living, so long-term care. And then we have DJ3 joining us from Health Point, so a community clinic perspective. And what I'd like to do is just moderate a short panel here with Kim Anderson, Angie Graves, and DJ3 to get the conversation going a little bit. We will have some time for chat questions and discussion. Keep in mind as well, jot your questions and thoughts down, because we can take those into the breakouts when we do so. So I'm going to start with you, Kim. And here's what I want to know from the Swedish perspective and experience. And you can reflect on that data or just dig right into what Swedish is seeing. Tell us your most critical roles or occupations right now, and give us a sense of numbers. How many open vacant positions in each of those do you currently have? We'll get into the couple other questions after we hear that.
Sure, happy to. All right, everybody, this is going to be a huge surprise. You're not going to expect this. Our biggest need in our workforce is nursing. I know, breaking news. So last I looked, there were over 600 open nursing positions at Swedish. And that's down from what it was before. And sorry, I have a tiny intern here today too. So that is far and away, and I know that we all know kind of that this is the case, and there are reasons why and root causes and all of that. But I can't not say it. Nursing is still our greatest challenge, and that is considering the fact that Swedish has a large nurse residency program where we hire, new grads right out of college and give them kind of experience, and then so the 600 it kind of goes up and down based on our residency cohorts, which are about quarterly, and we hire about 100 ish, more or less a quarter nurse residents, and then we hire, then we have a need for experienced nurses as well. So I know, shocking. And then, some of the other kind of higher need, of course, medical assistants are all, it's always been a challenge for a while with COVID. All of our medical assistant positions were closed essentially. Most of them are in the outpatient space, and our clinic volumes dropped immensely due to COVID, but our volumes kind of started picking back up, and though we don't have as many open medical assistant positions as we did pre-COVID, they, again, the same challenges that we had in hiring medical assistants are kind of coming back today. We have quite a few open, or I would kind of categorize them as early career administrative roles. Think registrar, patient service reps, front office folks who do administrative work. We have 5 hospitals, 2 ambulatory care centers, and over 130 outpatient clinics. So that role does tend to be early career, so it tends to be higher turnover. And so there's usually quite a few open positions there. And then NACs are another. So I think what Lindsay and I were talking about as we were planning for this day is the news is that there's not really news. There's the same positions that we needed before, we need today. And yeah, we've adjusted for volume a bit because of COVID, but we did it very quickly, very early on, to say what do our volumes look like? How many open positions do we have? Should we have these open positions given the volume, et cetera? And so what's today is reflective of our kind of flexing to respond to COVID. But yeah, no big surprises from us over here at Swedish.
So Kim, let's just dig in a little bit more. I think you covered a lot of what we wanted to hear just at a high level, the critical roles and occupations, no surprises, nursing, MAs, NACs. Also, hearing you say we've adjusted for volume. So tell us what that means. We assume that means sort of based on anticipated changes in patient loads and revenue, which we would assume a hospital has to do on a probably weekly basis. Tell us what that does mean to adjust for volume, and then anything else you can say about how that has affected your anticipated hiring coming up.
Yeah, so when we went into the COVID surge, we had a lot of open positions to start. So when COVID hit in that first surge in the spring, we did what most healthcare organizations did, which was freeze. We froze, right? And we focused most of our energy on taking the workforce that we had and understanding how we could move and skill quickly and support kind of what we thought was going to come with COVID. And after about a month or so, then we kind of, things started to feel like they were leveling. And we said, okay, we do not want to have open positions. We do not want to be hiring people if we know that volumes are going to be consistently down about 12%. I think 12% is the number that I have in my head that I've heard from kind of finance and ops leaders, that it looks like about, in the hospital setting, I'm talking about our hospitals, not our outpatient clinics, because it's a very different environment. It looks like there's been about a 12% kind of decrease overall in patient volumes. And so does our staffing and our open positions reflect that? And so the operations leaders of the organization really said, all right, everybody take a good hard look at what open positions you have, what are you asking for, and are you, has COVID changed that? In some departments that were hard to recruit for, it hasn't, or it made it more difficult, right? ICU is always hard to recruit for, and then COVID hit and the ICUs were kind of strained, and we needed workforce like never before, right? And in other departments where, let's say surgical departments where our elective surgeries dropped and because people are not, they're not as likely to run to an outpatient clinic or do an elective surgery because they don't necessarily want to be in the hospital right now. Those volumes, have been impacted. So very early on, asking, everybody to look at those positions so that, again, we weren't hiring people and then having to adjust to volumes later. We wanted to make sure that everybody who worked for us could continue to work for us and make sure that they were well taken care of in this uncertain, scary time. But the number that I've heard, I just called out, around 12% is what we adjusted for and anticipate the volume to kind of stay there in this environment. Again, it's hard to, nobody has the crystal ball, but the numbers of positions that we have open now reflect that.
Great. So I want to make sure we have time to hear from Angie and DJ3 too, but I'm just going to make a point that maybe we'll come back to, Kim, and what I'm hearing is that clearly you had a priority to try to take care of your employees that you have now, and especially your nurses and your MAs. Yeah. And so think a little bit about what you might comment on related to turnover observations, if there's been any shifts or changes there. Yeah. Because I can tell in some of the chat box comments too, there's big questions, especially around MAs, right? Mm-hmm. Such high demand, but because they can be sometimes a lower paying job, what's the incentive? And so I think any comments you might have, or quick comment you have on turnover, yeah, before we get to Angie would be great.
Yeah. So turnover has dropped just because of the nature of unemployment and the environment. In an uncertain environment, it's, no surprise that turnover is declining. The question about MA's demand and salary is a really interesting one. And it's something that we talk a lot about on the HILT, right? Because large organizations with larger kind of balance sheets have more flexibility. And so we could get into this kind of battle where we're like, I'm going to offer a $2,000 sign-on bonus, and I'm going to offer a $3,000 sign-on bonus, and and I see DJ3 shaking his head. What does that do to HealthPoint? What does that do for organizations who can't afford to do that? And what does that do for our patient care? So it is something that we think about a lot. We need MAs. Our clinics struggle. Our departments and our units struggle when we can't hire MAs and nurses. And there is the thing, the quick reaction to be like, well, we're going to pay them more. We're going to do the sign-on bonus. We're going to do the retention bonus. Let's do that. And one of the things a mentor of mine has said is what somebody has come to you for is what they will leave you for. And so if they don't have a good experience, if they don't feel fulfilled in their work, if the environment is not inclusive and equitable, then $2,000 sign-on bonus, they'll just go until they find a department that feels good and like work home to them. And so what I think is pay is obviously important. People need to make living wages, but the environment in which they work and the satisfaction that they find from their job is what's really going to keep people with you. And it's something we think about a lot. We're doing our engagement survey right now and asking people, how do we make this environment better? So.
Thanks, Kim. So yeah. I want to make sure we give Angie and DJ3 some time here, because clearly that some of these questions will feel and look very different, right, depending on these different settings. So Angie Graves, Head of Executive Talent Acquisition at Aegis Living, I'm going to turn to you now and ask the same questions. What are your most critical roles and occupations? Give us some numbers, how many open vacancies, and then give us an idea of what has changed. And have you had to volume adjust, and do you have anticipated changes in staffing coming up over the next 6 to 12 months? Angie?
All right, thanks, Lindsay, and thanks everyone again for being here. Really appreciate having this dialogue between our educational partners and other healthcare leaders in the area. So for assisted living and memory care, which is what we specialize in, COVID definitely had, I think, a little bit of a different, I guess, push on us than it may have from others, because we are clearly taking care of the most vulnerable in this time. And so we have not seen a lot of changes in our needs. What we have seen are some increased needs, specifically in guess what, Kim? Nurses. we need them too. So with our wellness nurses, which are typically RNs, but can also be LPNs, we have decided to move with COVID to 24/7 nursing, which is something that we haven't had in the past, just to ensure that we always have a nurse on staff and there in case any issues come up, and COVID has brought that to surface for us. So that's brought up additional needs. Now for us, we have 14 needs for wellness nurses, but also understanding what that volume looks like for us. That's a 25% vacancy rate for us. So even though it sounds like a low number, it's a pretty significant number for us and for what we need to care for our patients. Our other significant need, which is always significant for us, are our caregivers. So those are typically home care assistants or certified nursing assistants, or folks who want to become certified nursing assistants. We actually have developed a CNA academy in-house to train folks to do the work. But we've got about 80 open positions there right now, which is pretty significant. And what we've seen is we have seen a pretty big flux in volume of applicants. So at first, we saw quite a few new applicants with the unemployment, increase. People were getting laid off from hospitality, which are, folks that we can usually bring into our fold. But we also, with that, saw a huge increase in ghosting, no-shows for interviews. So we really realized on our end we needed to look at things differently and how we were qualifying and talking to people about their interest in the work to make sure that we were really attracting the right folks. The other piece that has really, I think, shifted for us as we've thought about staffing, as our communities have thought about staffing, is understanding the importance of agility in all of our roles, because when we had to immediately shift from, for example, our residents eating in the dining room or the restaurant area to having to have their food taken to them in their rooms because they were isolated in their rooms, that shifted the whole workflow. It created an opportunity to really help people work outside the boundaries of what they thought their jobs were, and really creating an environment where everyone just really had to pitch in wherever they needed to in order to help and make sure that we were still providing amazing care for our residents even during COVID, which was really tough. Life enrichment was another area that has just really shifted and changed a lot. So for us, it's been a lot about agility. We've had no decrease in needs whatsoever.
I'm on mute. Thanks. Thank you so much, Angie. I think, right, a starkly different picture in many ways, right? Because it's not like patient volume is changing in your situation,
right.
And yet also a lot of similarities, especially on the nursing front, that this is a very high demand need, and similar to what you were saying, Kim, different positions having to be stretched in ways, right, and be agile to fill certain voids. So let's jump to yet another healthcare setting, the community clinic setting, and DJ3. Same questions. We want to know what your most critical roles and occupations are. Give us some numbers of open and vacant positions, and then tell us about what's changed from a staffing perspective. Have you volume adjusted, and what are your anticipated changes coming up related to staffing?
So for us, the big three are medical assistants. As of today, I have 20 needs for medical assistants. Dental assistants are my second biggest need. I have 16 needs there. And then the area that is probably got the most attention that we're trying to really put our arms around is our front office. What we're seeing there is now we're up to 19 folks. And when we talk about that front office, we're talking about folks who are doing that initial greeting of patients, doing scheduling issues, making sure that they're prepared and ready to be handed over to that MA who handles the rooming and starts that tenure work. So that's where we're seeing the biggest impact at today. We need nurses, but our needs there are a little more focused because of the nature of the way we deliver care. So unlike, because we don't have, for example, people in the hospital overnight or things of that nature, we don't necessarily have that heavy staffing load. So we are able, for the most part, to leverage nurses. We still have 6 positions open, but we're able to use locums, temporaries, agencies to kind of help fill that need today. Long term, as we move forward and begin to continue to grow and expand as we are doing, we see that we will have increased needs for nurses as we continue our journey. Level setting, we've absolutely had to do that because we try to provide an integrated care kind of concept. And what we mean by that is at each one of our clinics, we try to offer more than just primary care. So we're trying to give you primary care, we're trying to give you dental, we're trying to give you behavioral health, we're trying to give you pharmacy, all in the same facilities. And so what we found was our dental folks were impacted the most because of COVID. So there we then realigned the workforce, and some of those critical things that you didn't think about before, such as screeners for people coming into your facilities to do the COVID checks and things of that nature. We had to reallocate some of our folks to, so our dental folks stepped up, took on those challenges of being those folks, putting those policies together, being part of our PPE task force, and part of those things. So we've been very fortunate. We did not let anyone go. We did refocus folks. However, we have been experiencing loss due to the realities of COVID. A lot of our folks are young parents who now have multiple kids who are out of school, who just cannot be a full-time teacher, a full-time parent, and also a full-time employee. Those things are really hard to do. We've also shifted some of our visitation. We moved from in the clinic, as we saw those numbers going down, we began to transition to virtual. So we started moving more and more appointments into the virtual space. We're still looking to promote that space. That required some of our talent to kind of reprioritize. Rooming someone in the virtual space is very different than rooming someone in the physical space. How to use the software, how to use the technology, things of that nature. So we've been doing some of that training and that learning also. From a budget perspective, what we've been able to do is really focus on some of the work that we've been doing around quality. As a federally qualified health center, we are supported by the government through some of our quality initiatives, improvement initiatives. That's brought some dollars back in, which has allowed us to keep the doors open. But as we look down the road, we absolutely see a new need. We just opened our Sunset facility in the Renton Highlands. We look to expand in the next couple of years, and we cannot do that without. So that somebody put the question, does virtual care decrease the need for new hires? In some cases, yes. In some cases, no, because your virtual folks need to have some technology knowledge. They're using those tools. There's got to be a level of comfort with Zoom and how to troubleshoot and those sorts of things. So there has to be a level of comfort there. So some of the folks that you are looking to bring in are people who also have, not only do I have the medical background, but I also have a little tech background combined there. So we've been focusing on that, and hopefully as we move forward, we look to partner to continue to create that healthy pipeline. And to speak to what Kim said earlier about, and I've said this and shared this about the cannibalization. Sometimes in healthcare, it's the biggers And they're not doing it intentionally, but they're trying to meet their needs. And so they offer this, and then I got to offer that, and they offer this. And that competitiveness sometimes creates turnover in all of our organizations, because you'll get someone who will say, I'm going to go over here and get this bonus. And I'll work the time frame required me to realize the bonus, and then I'm going to leave that organization and go somewhere else chasing after another bonus. Not saying most of our people are that way. That does happen to some of us, but that's where we really got to be unified and work together. If not, we just continue to eat each other up.
Great. Thank you, DJ3. So here's what we're going to do. As you know, the purpose of this info exchange is two ways, right? And so being able to hear directly from Kim and Angie and DJ3, thank you. And being able to look at those hard numbers, right? So again, I'll echo what you said, Kim, no surprises here, right? I mean, easily over 5,000 current openings for nurses, and then medical assistants, dental assistants in the 1,000 range, CNAs, very, very high. And then some of those front line workers, or I should say front desk workers, also in the upper, higher hundreds. So no surprises, the data speaks for itself. Very interesting to hear also that the demand is going to stick and stabilize, even though you have had to volume adjust, but around those critical roles, it seems it's going to stick. Absolutely added skill sets, to your point, DJ3, around virtual and technology, and shifts being made there, which of course we could predict. But now we want to switch to the other side. Now, this is a great opportunity for you as healthcare organizations to put your questions in the chat box, because we're going to switch now to hearing from a panel of educators. And so I'm going to turn it to a co-convener. We are the convener trio, myself along with Liesl Skilperut from the Workforce Development Council, and Ryan Davis from Seattle Jobs Initiative of HILT. So Ryan, I'll hand it to you to moderate the education panel.
All right, fantastic. And big thanks to Chris, Dan, Jennifer, and Kumhee for joining us. So we have a great skill set here represented from the education side. So the first thing that I want to throw out, and I'm going to pick on Chris first, because in a previous life, I was a dean at a community college, and I can just imagine, as I heard from my friends that are still in those positions, the craziness that was happening in March when we were all responding to COVID. But really wanted to tee up, as you've gotten past that initial fire drill, Chris, what have you seen in terms of student demand in your healthcare programs at Renton Tech?
I think the student demand is still there. Right now, currently our enrollment is down, but we hope that the enrollment will increase as a result of industry people losing their jobs. And so what we're looking at is being able to serve as a vocational rehabilitation center for those people that lose their jobs, that are going to come into the healthcare realm. Currently, the college community is working toward, we've had a great time at having a good COVID plan. I think across the board with the community college system here in Washington, we've had a really good plan in terms of getting students back on campus and getting them into their roles. One of the disappointing things I would say, though, I think when the governor he really didn't talk about higher education at first. And so that left the healthcare workforce up in the air. And so now, with all of our plans, we have pivoted. Most of our classes are online, hybrid. And now we have classes where students are actually in labs, because all of our programs are accredited, and co-accrediting bodies, our students have to have a certain amount of hours, they have to have a certain amount of cases completed before they can sit for their national examinations and before they are given licenses, certifications, and or being able to obtain their degrees. And so that was a big important part too. The only thing I think that we really ran into, which I'm glad the clinical partners are on this panel, we had situations with our clinical partners where we weren't able to generally do our clinicals at the times when we were supposed to do them. So it's kind of set us back a little bit in terms of, from our side, having to schedule clinicals a little bit later based on, you know, what the clinical site's needs were at that particular time. So it set us back, but now I believe we're back on track in terms of getting students out into the workforce. And I think students are excited about, you know, what this next phase is going to look like. They're definitely excited to be back on campus and be back in class and, you know, obtaining those skills that they need to get out there into the workforce.
All right, great, thank you. And so, Dan, does that reflect, you work statewide as with the Center of Excellence with all 34 of our community technical colleges. Does what Chris shared, is that what you're hearing kind of from across the state, or are you hearing some differences out there?
I am hearing a lot of similarities to what Chris just mentioned. There is some real divergence, or just, in fact, we just came off of a meeting with our allied health and nursing deans and directors around requirements for PPE. And so there's really no consistency around those requirements across the industry. And so I am actually going to be reaching out to a number of industry partners and organizational partners to see if we can get some consistency or consistent messages. And I think what Chris referenced in terms of, and what I heard earlier, higher education and health workforce development programs haven't necessarily been at the table in terms of identification of need in regards to things like PPE. I'm really glad to hear that clinical training is being worked on, and that it's no longer a serious bottleneck as it was. Yeah, so anyways, yeah, that's kind of my initial response to that question, Ryan.
Okay, great. No, that's excellent. That's good to see. So that's great from the community college perspective, which of course has, you know, lots of different healthcare pathways coming in. But also on our panel we have our four-year partners represented. So Dr. Rowe, I'm curious what you're seeing in terms of pipeline in the College of Nursing at Seattle U. Are you still seeing that same demand in terms of new applicants that are coming in? Are students still you know, pursuing that nursing degree? What are some of the trends that you're seeing?
Yeah, thank you, Ryan, for opportunity to participate in this panel. Yeah, we're still seeing a very strong applicant pool. As a matter of fact, I think this coming year, I think they're going to increase the number of the RN students, and traditional students. Something that I wanted to just echo what Chris and Dan said about the clinical sites has been a huge challenge because of the COVID, and especially for our advanced practice nurses, so they're practitioner students, and how some of them need to delay their graduation just because they couldn't get placements, and we understand that with the healthcare and COVID situations.
Okay, so we're seeing a little bit of a delay in the pipeline for those RNs and advanced nurse practitioner positions. So groups that might have expected to graduate, say, at the end of the summer, the end of fall semester, might be extending for another semester in order to get those clinical hour requirements.
Yeah.
Okay.
Practitioner programs.
Okay, which definitely does not help our friends at Swedish that need 600 nurses right now. So, Jennifer from Highline, anything to add to what our other three folks have talked about on the pipeline?
Well, I think we talked a little bit about the clinical backup, but I want to talk about nursing assistants in particular. That I think Maggie may still be on this call, but she currently has 100 or more students backed up who didn't get to go on clinicals. I think the last I talked to her, she said about 40% of the students were able to get the NAR and get hired to serve those hours. And now they're working on simulation, but just something that industry and schools could work on together. And I know that everybody's scrambling to deal with their own stuff right now. So that's it. And then just one other thing, because somebody mentioned how educators and students were kind of thought of second after all the initial crises. And somebody in our earlier meeting pointed out that a survey came out from the DOH yesterday that a lot of you may have gotten on prioritizing who gets the vaccine. Neither educators nor healthcare students were mentioned anyway in the survey. So.
Right, right. And I think as we look forward, being optimistic about that vaccine, that, we would assume that that would be a requirement before somebody was able to enter into a clinical setting, which is pretty key. So definitely a place to raise the voice there. So the second thing we kind of want to talk about is, obviously COVID is stretching budgets for those, particularly in the public sector. The good news is that the state's anticipated deficit of $9 billion has been cut in half to a mere $4.5 billion. But that's still a rather large deficit that's there. And of course, with the declining enrollments, that impacts top line revenue for colleges as well. So just want to go around, and I guess we can kind of keep the same order. And Chris, have you experienced any budget cuts in your healthcare programs, or are you expecting to have to make any cuts in the foreseeable future?
Say no to that. Currently, we've been lucky enough to say that we're not going to have to cut. As far as our equipment budget, stuff like that, we've actually applied for COVID relief funds and received that. Certain things. So we've been lucky as far as that. As far as human resource, I would say no. We're not going to be cutting anybody.
Okay. All right, excellent. Dan, from around the state, I know different colleges have been impacted differently. Are you hearing on places that are making cuts into healthcare programs as part of overall budget cuts?
No real impact, but a lot of struggles, particularly in regards to accessing funds to get PPEs. And the other thing actually that I've heard from both Jennifer and Chris in the past is, monies or funding for simulation and training programs. Since so much of our focus has been shifted over to online, it's essentially how are we replacing or supplementing those areas? And I think that might be a great opportunity for potential partnership with industry.
Okay, great, excellent. Kumi, from Seattle University as a private four-year partner, how have your budgets been impacted, or have they not yet?
Well, at the university level, there are definitely some budget cuts, but in the College of Nursing, I think there isn't a direct impact, except we're still short of faculty for many reasons. And something that Washington Center for Nursing, which looks at the workforce, as well as Nursing Commission, also looking at pipelines and the needs for Washington State and the nurses. And they're also looking at not just diversity of the students, but diversity of nursing faculty as well. And those are initiatives they're working on as well.
Okay, great. And on that, do you think that the budget constraints are going to have an impact? Are those DE&I initiatives, which we know are really critical to ensuring that our future healthcare workforce looks like the communities that we're serving? Do we sometimes those initiatives take a back seat when budgets get tight?
I mean, I think that it really shouldn't. It should be the priority, right? Because
yes,
the health disparity, or I think that's something that should be prioritized.
Okay, excellent. Jennifer, at Highline, how have you all been able to respond budget-wise?
Yeah, so we have a really humane administration who came up with some creative solutions, which I appreciate, because Highline was hit pretty hard. Like Renton was hit earlier, and now they're doing better, and Highline's kind of being hit now. So huge budget cuts across the college, not directly in healthcare, but what it means is that all programs need to see enrollment at the levels that they have to be to meet the costs, whereas in the past there was a little bit of leeway. So that's something to think about in the future, that if we're snipping away and making things have to be at the maximum level of enrollment, that kind of thing, we could lose things. And also we could lose programs. So what we need from industry is to tell us, the stuff we heard today was excellent, right? So what we need from industry is to tell us, which programs do you need us to really get behind, and which programs should we, you know, let go of and be sad and give a hug to?
Okay, great. All right, great. So I did want to throw out a question from DJ3 put into the chat. And he said, as you move forward, do you see more technological skills learning being added into current programs? So for example, electronic medical records, being able to use virtual visit platforms. So in this environment, has any pivoting happened to be able to add those skills into those pathway programs?
I would say yes.
Uh-huh.
Right now, a lot of what we've done before previously, a lot of our learning now is online, but we still have a lot of those components within the majority of our programs. We're also trying to create a simulation lab, or what we call the RTC hospital clinic, where we will have virtual scenarios where students from all programs can work together in a healthcare setting, just as if they were in a hospital itself. So we're learning to look at, you know, situations like that holistically and try to tackle, you know, what we can do right now in terms of COVID. But we realize that the technology piece is important for students to have before they can go out into industry. So that's what we're doing. We're planning to do an RTC clinic hospital, which will have simulation, but also have all of the things that David mentioned in the chat.
Okay, fantastic, excellent.
And Ryan, I want to,
yeah, go ahead.
I just add to that, and kind of going off of what Angie was saying earlier, and I really appreciate Angie being on this call, because she has a long history of lots of different types of organizations. And her reference to the fact that we have to be training health workforce students to be agile, I think is absolutely crucial. And what Chris was saying in terms of, you know, developing team-based interprofessional education is exactly what we need, but we need to make sure that our industry partners are telling us that's what we need.
Yeah.
Because honestly, some colleges are a little slow to move, and they need industry providers to insist that this is a direction that we need to take. Because honestly, if you don't insist, they may not go in that direction. Now you've got some innovators like Chris who are willing to, you know, really push that forward, but really have to have our industry partners say, yes, we need more team-based interprofessional practice that's putting out agile, flexible, nimble, responsive health workforce students. So I mean, I can't, that's, and going back to what Kim said earlier, there's not a lot changed in that. We have to have industry partners on our advisory boards sharing that information.
Yeah.
Let me add, this is Yasmin from Renton Tech. I'm Dean of Nursing. Me and Chris and we all work together. I wanted to add one thing. Our nursing students, we incorporated since COVID hit, we incorporated virtual simulation, and everybody knows how virtual simulation, how it gives robust experience to students, but we also incorporated it's DocuCare. It's like a Epic system where students are charting, where and we also bought a Laerdal mannequins, where it's a high fidelity mannequins, and you know, Chris and I, we are all working together, where you know, where we are team building his students, and we all both are working together, that we are team building, collaboration, and that's what we need to show it to, that it's when you go out, it's not one person are running the show, it's team building. And that's what, and how you collaboratively document, how you collaboratively take care of a patient. And that's what you, and that we have a mannequin and that can breathe, talk, system change, it all has everything in it, and run the scenario into that. And it has everything with social distancing. We have everything we can do in a control environment. So it's a great learning opportunity for students. Even during this short period of time, we can do that.
Great, thank you. So one comment I did want to share from the chat before we wrap up for our panelists is that Kim had mentioned in the chat around how industry partners that have training dollars or tuition reimbursement dollars, how we can be able to leverage those to be able to drive enrollment. So our incumbent workforce being able to go and drive those FTEs and tuition revenues in our healthcare partners and keep those healthcare plans self-sustaining. So I think that's a great point for conversations as we get into our breakout groups to be able to do that. And speaking of breakout groups, that is where we are at now. So if we can get a virtual round of applause or snaps for our panelists. So thank you very much, Chris, Dan, Jennifer, and Dr. O. Liesl, I will turn it back over to you to break us out.
Thanks, Brian, and thank you so much, panelists. Really appreciate time to think about some of those hard-hitting questions and sharing with not just your colleagues here in industry or in healthcare or in education, but also with our partners in industry and in education. So I'm going to break us out into 2 breakout rooms, and myself and Ryan will be very lightly facilitating these conversations. You'll see on your screen some questions. We're going to ask a pointed question to our education providers that will be in each of the breakout rooms. What is your greatest barrier to finding clinical placements for students? And similarly, we'll be asking industry and healthcare providers, what is your greatest barrier to hosting clinicals for students? And then together, both industry and education, we're going to have a conversation about why this barrier exists, what's the root cause, and the most important is what will remove this barrier. And then when we come back, we're going to have some report outs from each of the breakout rooms. 2 notes, each room will be about 50% education and 50% healthcare. And then if whoever's phone number ends in 4000, if you wouldn't mind telling me your name, I want to make sure that your phone lands in the same breakout room that your video is, if you have a video. And if not, I'll just put you in a breakout room.
Hey, the 4000 number is me, Tanya Grant, I believe. And apologies, I couldn't connect via my computer with the audio. So
no worries. I will put you in the same breakout room as your video. You'll have 27 minutes in these breakout rooms, and then we'll reconvene around 4:25 back in the main room. And you'll get about a 60-second countdown when you're about a minute. So see you in your rooms.
Hey, Lucille.
Hi.
Hi, I have a conflict. I have a meeting with our directors that they just called at the last minute, and I have to jump on that call for maybe about half an hour. And then I'll jump back on, but I just wanted to let you know they just called a last minute meeting while I was on this Zoom call.
Okay, no worries.
I will join back in when I can.
Sounds good. Thanks so much. Okay, bye.
Partners. There's Liesl. Liesl, we just started. We were just going to jump in and just ask the question about the greatest barriers in healthcare organizations to placing students in clinical kind of rotations. And so I'm going to open it up. I don't want to be the only one talking here. So please, healthcare partners, if you have experience in placing student and clinical placements, what are the kind of greatest barriers to that process or hosting more students?
Hi, this is Tracy from HealthPoint. So one of our struggles was we did a really good job in the past with our MA externship, but when COVID started, like everyone else, there was a lot of PPE concerns and being able to have a safe environment and limiting people in clinic. So we really weren't able to host our externs. I think we're getting there now, but that was a really big struggle for us. And
if I could add something, or this healthcare, is this still healthcare? Sorry, I'm education, so I'll be quiet.
Well, hey, this is Tanya. I'm with healthcare without a video, but I totally agree with what Tracy said. There were some serious PPE constraints initially, and then we also had the added barrier at PACMed of having some union rules related to not kind of canceling our MA externs before we canceled our own staff, if you will, from an optics of hiring, of working people that were outside of the contract.
Tracy and Tanya, can you tell me a little bit more about this PPE concern? Is it lack of PPE? Is it the quality of it?
Yeah, no, it's definitely the lack of PPE initially. We were having to ration because PACMed is not associated with a hospital system. We had less supply chain initially in the pandemic, and so we felt like we didn't have enough for our own critical staff, and so that we couldn't spare that for any students, unfortunately.
that's similar for me as well. It was just making sure our regular system staff had enough. We had enough.
Tracy, can you repeat the last part of what you said?
Yes, it was making sure that our regular full-time employees had enough. We had enough PPE to cover, and limiting time in clinic as well.
I see a question that came through from Destiny on whether or not the PPE issue has been resolved. I know at Swedish we were very focused on understanding how many days on hand we had for PPE. There were some places and times when it was really tight, and it seems kind of nationally we got our stuff together, and there doesn't seem to be as much of a concern around the availability of PPE. You know, there was a lot of confusion about, does everybody need to wear them? Is it, eventually, I think initially in the swirl of COVID and understanding it in general and what was happening and what to anticipate, there was just a lot of confusion and concern, and not wanting to run out and have to respond to a lack of PPE. And so at least at Swedish, it feels to me like, I haven't seen the number of days on hand recently, but it feels to me that there is definitely a supply now. That doesn't seem like as much of a concern. Do you guys agree, Tanya, Tracy? Does it feel pretty stable now?
It does. It does. It's definitely gone well.
Yeah. Yes, from Tanya's perspective, yes, it absolutely does. And we really appreciate the work on behalf of, and the collaboration with Swedish and Providence Health Systems to move PPE around across the system so that we all have enough.
So if I could just ask a question about that, does that mean that you feel you have enough PPE to support students, or that you're stabilizing the PPE needs of your staff?
Hey, Tanya, again, I would say that we do have enough needs both for our handful of MA interns, as well as our current staff right now. So we are hosting our MAA students at the moment.
Thanks.
Yeah, I haven't heard recently at Swedish any news of kind of turning students away because of PPE concerns. I think it's been resolved. Okay.
Does that mean that clinicals are opening back up?
Yes, I believe so. I thought I saw somebody from our clinical education department on this call who would know much more about the exact situation at Swedish. But my understanding is that yes, we not just kind of clinical, like nursing clinical placements, but in terms of other workforce development programs, we have a very set kind of method of PPE, symptom monitoring, you know, very guidelines around which rooms you enter, which rooms you cannot enter as a student, et cetera. And so since we have had some months now to outline those guidelines and the symptom monitoring and the precautions and our caregiver, employee health workflows and contact tracing and all of that, it does feel like we are kind of back to a place pre-COVID. Though I'm curious to hear from education, I guess I'll ask one more question. I'm curious to hear from education partners, other education partners, like pre-COVID, it feels like, again, this isn't completely my area of expertise, but pre-COVID, it felt like there were still limitations around clinical placements. It was still, the volume of students that we could put through were dependent upon the ability to place students. And so even before COVID, even if we're getting back to before COVID, there were still challenges. So I guess I would just be curious to hear, I know we don't have a ton of healthcare folks, but Kevin, Tanya, Tracy, what were the constraints before COVID?
Well, if I could jump in, I'm kind of representing the HR department today, and this is my first meeting. So you pose a lot of good questions that I need to then go back and ask them the same question.
No worries.
Next meeting, I'll have the answers.
No worries. I totally understand.
Thanks for being here, Kevin.
Yes, thank you.
Yeah, thank you for having me. I really appreciate it. It's very informative.
I wonder if any of the healthcare partners here do NAC, in normal times, they do NAC placement.
I actually don't know if we have, and I'm in the same boat as Kevin, and this is not my first meeting. But I actually don't know if we have a NAC kind of training program. I would have to go back to my clinical education partners, and possibly they're in the other group, and we might get an answer when we come back together. I know that we are developing and thinking about how to do that, including kind of other careers, like an entry kind of job into NAC, even kind of prior to NAC. But I guess one thing that I would say is, I think at a higher level, a challenge that I see is just the kind of the shortage being a self kind of or a vicious cycle where it's people are feeling very kind of tired, burned out, they're short staffed, and so the then being asked to proctor or coach, while probably very fulfilling for people to do that work, is when you are kind of very busy at work and caring for more patients because your department's short-staffed, et cetera, that it then becomes pretty overwhelming to consider the idea of also being a proctor or taking on that role as well. So that's my I think that this trend of kind of burnout and being very kind of busy and having vacancy is kind of it's like I said, a vicious cycle.
Dealing with a reporting emergency simultaneously. So can you
Oops, sorry.
No worries. Okay. Well, if there isn't, Lisa, I think we can move over to education and.
Yeah, I'm really glad that you acknowledge the vicious cycle, Kim, of, we're understaffed, and we realize that bringing on more staff, calls for our current staff that are overburdened to become even more overburdened. And so I don't know if that's actually a place where, partnerships with other organizations like Clinical Placements Northwest or with education, if there's, again, I'm looking forward to how can we remove that barrier, right? How can we kind of throw a rock into that vicious cycle? But let's to education providers, and I'm going to put a pin in that and absolutely come back to it, because thank you so much for acknowledging it. So education providers, what is your greatest barrier to finding clinical placements for students? And I realize it's a broad question. And you can probably all say, like, they're just not open. But is that true? I see Jennifer smiling.
I don't think it's the fact that they're not open. I just think, like, for example, a lot of us that are in similar areas, geographic areas, we have similar programs. And so therefore, if there's only, 20 slots for MA, Jennifer has her program, I have mine, where else can we go? That's one of the barriers that we face. I mean, we like each other, but we're definitely in direct and indirect competition with each other. I mean, that's a fact. And so a lot of times, it's hard to create extra sections because you have to think about the addition of, clinical placement slots, which I'm blessed to have a clinical placement coordinator. Most colleges don't have that. And our coordinator actually works backwards. She has all of our placements for the year. So we know for the academic year, exactly how many slots we have. So if I add a section, that's going to cut into my numbers that I already have established for the entire year. So I think that's one of the main things is the actual numbers that the healthcare partners have created or given us. I don't think they're enough to have all of the colleges participate either in clinical rotation, external internships.
Can I add something? So though I'm the nursing program director at Pierce College, I'm also a board of director for Clinical Placements Northwest. So I understand and recognize the need for clinical placements, but I also recognize the burden of the clinical facilities in that I have board of directors that sit on that board with me that are clinical partners. And I recognize what it is that they face and what they do daily. And I think we try to work collaboratively together to find best practices to get folks clinical placements. And at the end of the day, I think the system is geared towards acute care. And I think there's a lot of conversation about how do we get a little out of this idea of everything has to be acute care. And is there a way that we can tap other places and resources besides acute care? I think fundamentally, and I'm going to try not to get on my soapbox, is that there's a lot of things that we can do, and CPNW can be a part of this. I think other programs can utilize this outside of CPNW as well, that we can do clinical placements and community practices that don't necessarily need to be in acute care. And so I think that there are different roads. Those things take time. And to Chris's point, not every program has a clinical coordinator. As a matter of fact, I just got a clinical coordinator, and previous to that, me as the nursing program director was doing all of that work with a little bit of help from my assistant. So while trying to run the program, I'm trying to also grab clinical placements while I'm like barely hanging on, which leads to nursing program director burnout, nursing faculty burnout, and you have these people burning out, then you don't necessarily have people teaching nursing schools, and then you've got a whole different problem, which is probably the same thing that you folks in the clinical are facing with nurses leaving the profession, which is a completely different thing that we could talk about, or why we don't have preceptors that want to take nursing students, right? So there's a system problem, but is there a way that we could take a burden off of the system, the acute care system, by thinking outside the box a little bit, at least for a short period of time, especially in the days of COVID, right? Because you are right, Kim, before COVID, we did not have enough clinical placements. And Chris is right. We are in direct competition for those clinical placements, in that I can't grow my program without going directly to CP&W and asking them for 8 clinical placements, and the state of Washington Commission will not allow me to grow my program without a letter of support from CP&W saying we guarantee those 8 clinical spots. So it is definitely a cycle, and I hope that that makes sense, but maybe going out and going outside of acute care, as much work as it seems like it is, and it is a lot of work, might need to be an answer.
Thanks, Tiffany. And I'm so glad that you were able to make it today and that you're in this breakout room. Quick question, were those barriers pre-COVID?
Absolutely, absolutely. Mm-hmm. And of course, COVID makes it worse, right? People are trying to still grow their programs. We still need nurses. We need nurses now more than ever. We need everything, respiratory therapists, NACs. We need the gamut of healthcare, which means we need all of those clinical placements more now than ever. And I think that there's more of a burden on the system than there has ever been. And so we really are going to have to collectively use our brains and put our heads together to figure out, okay, so what does this look like? I've heard some great things today. Simulation is a great way to go, but it can't substitute everything. And the state has our hands tied around that, and we just know that. There's nothing we can do about it. So we have to be, we're just going to have to think outside the box and bend the rules a little bit. And I don't know what that looks like, admittedly, but I'm willing to sit at the table for sure.
Thank you. And, you know, anyone else, please, education, please feel free to jump in if you have any other barriers in mind to finding clinical placements, but I do want to be wary of time. We have about 7 minutes before we get yoinked. So, you know, we can really dig into why the barrier exists and what's the root cause. But I think more importantly, what will remove this barrier? And I'm going to give the floor to Jennifer because it seems like you want to say something.
Yeah, just wanted to say on the upside that most of our healthcare, we don't have that many healthcare programs, not like Chris, but our RN and our RC, respiratory care, both are having great responses from their clinical partners, so they're coming up with clinical placements. I don't know if it's enough, but it's pretty good. MA, you know, thanks HealthPoint, thanks lots of places, they are finding MA placements and that kind of thing. But like I mentioned earlier, NAC is a whole different story, and I don't even know if any of our healthcare partners on here are long-term care or SNF or assisted living in this room. Any of you have that? No?
I don't think so, no.
Okay.
Although I would say for those in the acute care environment, we do have an acute care CNA class if you have a need for CNAs in the acute care environment.
Yeah, that's the other thing I was going to say, is that the whole acute care NAC thing is another conversation.
And we're looking for placements for them too. Just saying. But I agree with Jennifer. I think one of the big issues for the long-term care community, and I think the person from Aegis Living must be in the other group. Right now, skilled nursing facilities are not taking students, period. They won't allow visitors, so they're not going to take students. And to the nursing issues, a lot of students are doing a CNA as the first step on their pathway to nursing. So you're talking about downstream effects as well. It's going to be interesting. Jennifer said, well, what about post-COVID? And I think that's going to be an interesting question, because I think the issues of infection and the risks to residents, COVID or anything else somebody might be bringing in, is going to be much more of a concern given what happened with COVID. And so there may be, there may be some changes around, sort of having excess people running through a skilled nursing facility. I don't know.
I want to be kind of provocative, maybe. Tiffany, you had said, we need to change the rules or something about the rules to be flexible and respond. And this is a genuine question because I really don't know, but are there rules in particular that are coming to mind that are like, this is a specific rule? We know it exists for a reason, that it was set up that way for a reason, but is it what rules come to mind specifically that create some of those barriers?
Yeah, I was specifically talking about, and though these are out of our purview, and they have bent the rules a little bit. This is nursing specific. They did bend the rules a little bit for us, where they allowed us to use virtual simulation in spring. They don't typically allow us to use vSim to substitute for clinical. And so that was one of the things that they did allow us to do. Another thing that they've allowed us to do is to utilize the 2-to-1 ratio for simulation. So 1 hour of simulation equals 2 hours of clinical. So that is, again, nursing specific, and I don't know who else on the call is nursing. But I don't know that there are other rules from, and I know that everybody wants to go to skilled nursing facility, and I think that is fantastic, and I would be willing to put my nursing students at skilled nursing facility, but I know that they're off limits right now because nobody's taking them. So when I talk about other community-based things, I actually am I'm thinking about aside from skilled nursing facilities. And I said openly, I don't know what that looks like or what that is. But they can't take us right now for whatever reason. And folks that are getting to limitedly go to skilled nursing facilities are having such difficulties getting COVID tests. There's all this COVID testing that they're having to get in. It's been, at least I hear from my colleagues, it's been sort of a nightmare, and maybe some of you can speak to it a little more eloquently than I can.
Yeah, that might be SNF specific. We don't have COVID testing requirements. We just have symptom monitoring.
We've been hearing noises about requiring students to be COVID tested.
In all settings, or in
in the skilled nursing facilities.
SNF,
but that's
yeah.
why I threw out the general question, because I didn't know if that might be coming in other areas. We're doing, all the campuses I think are doing the screening already. But I say from the skilled nursing facilities, we've just been hearing rumblings.
Yeah. So I want to throw this out to the group because I've been talking about this with Laura Hopkins. She's the executive director of the training fund. And I've been really excited about some apprenticeship programs that have been created. We've worked on apprenticeship programs for medical assistants, for farm techs, sterile processing, and nursing is, there would be a lot of hoops, a lot of things structurally that would have to change, but I've got this like dream that someday we would have an earn while you learn nursing type program. There are rules around it now that wouldn't allow it, but just something that I am thinking about, and I am hoping as an industry we can work on this together. The healthcare industry leadership table as a group has the power to advocate. So to be able to say, this is what education is facing, this is what healthcare is facing, and these are the rules, and these are, where they might need to bend, and we all support this for, various reasons. And We did that with the presidents of colleges and universities, sent a letter and said, please prioritize healthcare education because we need the graduates, we need the workforce. And so as I'm thinking about like what are innovative kind of training programs that improve equity, improve inclusiveness in training programs, especially for organizations that require bachelor's degrees in nursing. I'm excited about the apprenticeship model, and I'm just in the early stages of dreaming about what that might look like for nursing.
There is something, and I don't know if this is what you're thinking, and I don't know if it's, and I'm trying to pull it up so I don't get it wrong, but there is something that's being offered as an academic practice partnership in Washington that is currently, that the commission has given some nursing programs the ability to do, where they, it's under the emergency rules that were granted by the governor, but for their practicum, which is their 6th quarter of nursing school, they've been allowed to work as nurse techs and get paid and get credit for that in their practicum experience. And so I think that's as close as we've ever come to getting to what you're talking about. And so hopefully that has opened the door for maybe a little more of that. It seems to be working.
That's awesome.
This is Tanya Packman. That sounds like such an exciting idea, and it's awesome, Kim, that you mentioned that. I was actually thinking that as you guys were talking.
Let's talk more. We're gonna get kicked off.
With down to the second.
All right, people are still making their way back in, so we're going to give a moment. All right, well, it looks like the same number of participants that left for a breakout room are back in the main room. So we're going to dive into sharing out from the breakout rooms. And we have some really great volunteers. Sorry while I bring up the slide deck. Really great volunteers that are going to help share what was learned in each of the breakout sections. And we've asked some of our industry partners to actually report out what they learned from education, and some of our education partners to report out what they learned from industry. So I'm going to go ahead and start with Shauna. Can you kind of give us some highlights of what you talked about in your breakout room and what you learned from education?
Sorry, Lisa. I had teed up DJ. I teed up DJ3 to do that from our group. I'm sorry. I pulled an audible.
I'm happy. I'm happy to give DJ3 a break because he always raises his hand for everything.
Okay, good, great, outstanding. All right.
Unless DJ is dying to do it, I'm happy to. I just couldn't find my unmute button, which is hilarious given how many times a day we do this every day. So I think the big things that we heard in our great breakout group from our education partners, I think were, in terms of barriers to clinical placement, early on it sounded like just a complete shutdown in terms of communication channels. So just some real confusion, and even the ability to kind of connect and figure out what was happening and make a plan. And then related to that, I think some lack of clarity around requirements related to PPE and fit testing, and perhaps even some changing requirements as you thought you were beginning to understand those. Mentioning, I think that there is some sign that things maybe are beginning to open up a little bit more now after some really strict constriction in the opportunities for placing students. That there is some worry among our education partners about that while it's encouraging to see things opening up again, some worry that things might contract if we start to see, obviously we're seeing some rising numbers, if things get worse? Or are we going to see things shut down again? And then there was quite a bit of conversation around student morale. Sort of what is the impact on students of the sort of both the changes in the educational model and the educational environment. So what am I learning and how am I learning, and how prepared am I going to be for healthcare, while at the same time dramatic shifts and changes in healthcare itself. So what am I even going into? What does this look like? I've done, especially students who are getting ready to graduate soon. So they've done training under one model and now they're coming out, and the expectation that I'm going to do telehealth all day, and am I prepared for that, right? So some real strains, I think, on students in terms of their expectations about both education and work life after school. And then I think related to that, some mention from our education partners about just some fear on the part of students about, while in some cases struggling to find those clinical placements, also some students who are actually anxious about going to those clinical placements in terms of safety concerns, and collectively what all of those things have done to potentially delay graduation in some instances and in some programs. And then I think finally, some mention of the ethical considerations for schools themselves. So with a lot of desire to help students finish and to get students those clinical experiences they both need and benefit from, wrestling a bit with the ethical considerations around placing students in a clinical environment where there are clearly some uncertainties and some danger. And I think the last thing that Dan did say as we squeaked out of the break room was just some thoughts about just that fear in general for students and for staff, and what are the behavioral health impacts of the kind of strain of that on both people who are working in healthcare and students who are training to work in healthcare.
Great.
Thank you. So I will actually go ahead and ask him to report out from our breakout group around what the education providers were saying.
Yeah, happy to. We talked a bit, or we heard from education partners that one of the challenges that they have is that because there are limited spots in healthcare, in the industry, that oftentimes they're competing with one another for a limited number of spots, and they need to have those clinical placement spots lined up before they can start to kind of enroll students, and making sure that they're going to be able to graduate, get the get the experience that they need to graduate. One of our group members called out that the system is really geared toward acute care, and that we may be able to kind of tap other places and resources to create clinical placements in other spots. On the flip side of that, what we also heard, we didn't have any residential care or skilled nursing facility participants from the healthcare side in our group, but the education partners were sharing that we can't place students in SNFs because of COVID. Either they're not taking students because of the risk to the very kind of at-risk populations that reside in SNFs, or they require COVID testing, and those tests are hard to get. So there were kind of those systemic issues. One of our education partners called out the fact that they are fortunate in that they have a clinical coordinator in their program to be able to really lay out the number of clinical placements available to them for the year, but that not all education partners have that function. And so they're at an advantage, which puts others at a disadvantage when it comes to identifying the spots. And it goes back a little bit to the competition element.
Great overview, Kim. Thank you so much. Now I want to jump to two of our education providers who are going to report out what they heard from industry in their respective breakouts. Dan, can I start with you?
Sure. So this is going to be a theme that we're going to keep hearing about. And one of the things that we kind of heard right off the bat was just the issue of managing risk. And particularly from the beginning of responding to the pandemic. So because our industry partners were so focused on just managing risk in their setting, the idea of bringing people from the outside who weren't employed was overwhelming, really. And so just that issue of managing risk and the risk potential was a big barrier. The next we heard about was the shift in programming and how healthcare was being delivered. And so essentially there was changes in patient loads and changes in programs. And so there was a lot of adjustments being made. And so not really being able to respond to dealing with students because of all those adjustments. We heard a lot about the importance of, again, managing risk, but specific populations, protecting residents, like in long-term care facilities, just current regulations just prohibiting students from being in those facilities. And also, even like Shauna brought up, the vulnerability of patients who are receiving real critical care, like in the children's hospital, and protecting them. So, and then the last but not least was just the bandwidth of industry to be able to provide a valuable training experience, just because of their focus being overwhelmed with just managing what they were dealing with. And I believe Shauna also said towards the end there that there's a real need to kind of engage in or be experientially in this kind of ebb and flow. And what I heard earlier, you know, education programs kind of require some real concrete feedback about opportunities, and yet the industry partners are requiring or needing a real flexible kind of ebb and flow conversation around this. So that to me was just kind of really an aha moment there. Sorry to get I'm beginning to editorialize already. All right.
That was great, Dan. Really appreciate it. Jennifer, could you report out from our breakout room? What did you
Very similar to some of the stuff Dan said, but we had a lot of conversation around PPE because, drawing from the earlier conversation. But it does sound like from most of our industry partners, although that was the initial concern and the initial reason for clinical, for not taking clinicals, that's changing a lot. That the initial concern was around a safe environment for all, and having to make sure that full-time employees were covered first. Another person mentioned that there were union rules about not canceling, full-time, you can't take an MA extern if you are about to let go a paid MA, that kind of thing, which is a very recent, very real thing. Let's see. Now it was, then there was this evolution of understanding. Once there's a stable supply of PPE and we think that there's enough now, everybody said they think there's enough now for both employees and students, so that's pretty cool. And also that there's been an evolution so that for example, the guidelines are really explicit now, so where people can go and having screening and that kind of thing. So there's a lot more comfort at having clinical placements in these facilities. However, one big barrier that's still a truth is what was sort of mentioned already, which is when staff are already being overworked and they're under stress, and then they're also asked to proctor on top of that, that might become a burnout issue. So I think that's about it, unless anybody else from my breakout room thinks something was missed.
I think that was great. Thanks, Jennifer. I know that, we didn't have, hours and hours, and I think at least in our breakout room, by the time that 1 minute countdown started, we were really getting into the meat of, what could a solution to this be? At least in our breakout rooms, there was definitely a conversation around exploring, embedding other ways of learning into the way industry is hiring people. So apprenticeship brought up. And again, that was like right as the countdown was starting. And so I know this says joint advocacy needs, but I want to just kind of open the floor here. So feel free to unmute yourself or include in the chat box any of your ideas around, anything that you've heard in direct response to what the education partners have said or what the industry partners have said, and some cohesive next steps that we could explore as a group or maybe a subgroup to get students into clinicals.
I think one of the things that we can do moving forward is have constant communication with each other. I think we have our meetings bi-weekly, and it would be great to have a couple of the industry partners to join so that we can discuss, the concerns that we have. But I think this is a great start to that deeper conversation. There were some great things that were said today. There were some things that probably both sides did not know or understand. So I think if we keep the communication open and we continue to have open dialogue, we can have some really good solutions to these concerns.
Thanks, Chris. I saw a very enthusiastic head nod. I think DJ3 did a dance. So I definitely echo that. And I think HILT can be a forum to help continue this conversation in 2 weeks, in a month, in 2 months, to make sure that industry and education, that there is a clear line of communication between the two, so that when another huge wave of COVID cases, knock on wood, does come and healthcare providers are maybe scrambling a little less because then they're done, did it really recently, but can communicate with education very quickly about needs, how they're having to shift and how that might affect students, graduation, etc. Is there a specific kind of task associated with keeping an open line of communication that this group would want to kind of put into place?
I know Chris has called out some forums where the industry support would be useful, and so possibly just using the HILT function to let industry know, like, hey, this is coming up in education, this is coming up in a legislative cycle, this is coming up in whatever, and we need industry to come alongside us. So just I guess what I would ask is if education leaders are in thinking about those conversations and preparing for them, to go through Lindsay, Liesl, Ryan, and say, hey, HILT, we need you to put the blast out to the industry that we need support and advocacy in, here's the meeting, here's the date, here's what we're going to be talking about. And I am sure that you'll have many of us kind of volunteering to support in whatever way you need.
I also would like to add to that. I think we need to begin to leverage cross-pollination. And Chris kind of spoke to this about there are a number of meetings that are going on their side of the fence. Having someone from HILT come in, maybe a quarterly, whatever that right rhythm is, to just kind of continue the conversation, can start to develop relationships, because contrary to what we think, organizations don't make things happen. It's relationships that make things happen. And we build relationships by connecting with one another. So it's someone from HILT coming, connecting with them. It's someone from, and it's us at HILT actually making an agenda space for them, our education partners, to come and share with us specifically on this topic. As we continue that dialogue, I think we'll begin to see places where we can fit. We'll see potential places to partner, and then we can begin to leverage those things.
So I convene those meetings that happen every other week with the allied health deans and nursing deans. And I think it would be awesome to invite members of HILT to those meetings as a way of continuing kind of the strategizing to address these issues. But I think it might be worth kind of, I don't know, doing, I don't know, almost an analysis of this meeting and coming away with a couple of key, what I would call pain points or areas of tension or challenges that maybe need some directed strategy or, you know, thinking about what do we do about this. So I'm just putting that out there.
Yeah, I think that one thing is I was kind of reflecting on our conversation is that I think that realization is setting in that this is not going to be over quickly, that this is going to be a multi-year challenge. And so, you know, there were definitely some short-term barriers that, for lack of a better word, were or are insurmountable. And the CDC says thou shalt not. That is there's no amount of collaboration that's going to overcome that barrier for our friends at Aegis. But in other places, starting to innovate and think about those things where we can nibble on the edges, that it's not an all or nothing solution, but it's a progressive solution.
And Ryan, maybe building on that point, and to your point, Dan, which I really, really appreciate, because I think when I think back, Kim and DJ3 and Shauna and Angie and others on the HILT captains team, when you were sort of envisioning this, you really did want to walk away with some real practical, so what is it that we're doing together? And so I'm hearing, you know, one very practical one is just find ways to really keep that communication much clearer. And what we heard in the breakout room from you, Dan, and maybe it was on the panel even, was like, it's that lag time and it's that like no communication. And that was really the biggest problem for students, right? Because you couldn't even tell them something about the future. You couldn't even foreshadow. There was just no communication. So communication, communication, communication. The other thing I heard though, and Shauna, I'm really fascinated by this. So I just want to call it out because to me, it seemed like a best practice. Shauna at Children's described, you know, back kind of probably early on, if you started taking students a few at a time in June, you put out to all your departments, if I heard this right, Shauna, submit back to us a plan and a strategy for bringing students safely back into the hospital. And so that to me is really interesting because it's very organized. You were able to then, you know, have kind of a, you said master spreadsheet to really understand, you know, what the different departments were suggesting and what volume control might have to look like. To me, there's best practices perhaps in the re-onboarding, right? Or the placing of students that perhaps we should be digging into more as part of that communication line. Exactly, DJ. Yeah, capture best practices, right? Like, at a minimum, right? Isn't that something that perhaps HILT could help do?
I want to give a little bit of space for anyone else who thinks they might have a good next step for this group. I realize the chat is blowing up and I have so many screens going on presenting and I'm trying to see all your beautiful faces. But you know, is there any other great kind of next step or action item? You know, Dan, I'm really intrigued to hear what are the key pain points from this conversation that we could really dig into to direct a strategy. And I think that to Lindsay's point, we've heard this communication, we just opened the door to this dialogue and we have to keep the communication. So to me, those are two really concrete things that us as the HILT convening trio can take away. Is there anything else? And
I said we should do an analysis, and that should involve what we call a polarity mapping. And so just kind of understanding the different sides and actually map that out and see where we can bring in confluence. Anyways, it's good collaborative practice, I think, would be a good place to start. And I'm sure we've had good collaborative practice. We just need to elevate it, as I heard in another meeting earlier today.
I guess one thing I would like to share out too is that the HILT captains sent a joint letter to all of the presidents and chancellors urging that while there's difficult budget decisions that have to be made, that not looking at that short-term drop-off or furloughs that happened in the healthcare side is indicative of the longer-term demand, that demand was going to persist for multiple occupations, and that now is not the time to be cutting investment in healthcare education. So hearing from the panel that has not happened in programs is a good thing for a sigh of relief. But the other part of that letter was an offer to the presidents and chancellors to do just this, to start to be able to collaborate across lines on clinical placements to keep that pipeline moving, but then also to find other ways of how industry can support by sending incumbent workers to our community and technical colleges, as well as to our four-year partners to be able to do that. So really creating that symbiotic relationship that was really on display here today.
Thanks, Brian. Thanks for bringing that up. I just wanted to highlight some things in the chat box. So it looks like we have a question around, does anyone offer preceptor training for their staff? And we have Swedish who responded that they provide preceptor training, but not specifically for students. There is a question around whether the Nursing Commission is involved to help from the legislative side. And I'm not sure we have anyone who could answer that question in the room, but I know we do have someone connected to HILT who is very, very active on the Talent Pipeline Committee who could address this question, Julie. So I could follow up with you after that, after this meeting. Let's see here. And then I really love your point. We could argue that COVID has highlighted barriers, and that could be used as an opportunity to address them and to find creative ways to kind of nip them in the bud once and for all. So I guess I'll go back to Kim's suggestion, and I think Tanya of PacMed kind of applauded the use of apprenticeship. But again, someone also how using apprenticeships, I believe it was Elodie, what to ease the hiring of apprentices when healthcare providers mentioned the vicious cycle, a need for more staff, but current staff is already overworked, so limited mentoring capacity. Let's see, and then finally, Shauna has answered Liz's question again around preceptor training for staff. Children's does do that. So
I was just throwing out though, that might be something to think about as a project going forward. I know, and this is from another country, but I know in working with educational institutions in Canada, they do a lot of preceptor training, and it really does have a positive effect on burnout of staff because they better understand. They don't see students as a burden as much, to put it bluntly. They actually see it as a positive, and they actually can still feel like they're productive even though they have a student shadowing them. So that might be something that could be done across the programs, across the industry partners to develop some type of a preceptor program.
And we've also heard a lot in recent days, recent months about the necessity to do team-based interprofessional precepting. Yeah, lots of focus on that.
So there might be some opportunities there.
Interesting. Thanks, Liz. I'm actually going to reserve the last 5 minutes and give space for Kim and DJ3 to kind of wrap us up and bring us home.
Yeah, thank you.
Turn us off, yeah.
I just want to, I want to respond because I do workforce development for a living, and I've never met somebody who doesn't love to share their passion, their field, their experience. I've never met somebody who doesn't feel like that's worthwhile. I think that our healthcare system and the way that the business works gives us some additional challenges that we have to overcome in order to give students that experience and help ourselves create the future workforce. But conversations like these, the organization of HILT and having partnerships and to DJ3's point, those relationships that are built in this work, and really seeing that we're all in it together and trying to solve these problems creatively is just so encouraging. And I so appreciate all of you spending so much time here with us this afternoon. I think there's amazing kind of opportunity to take this work forward, to continue to focus on it in our HILT meetings and dig down into what this means. I will call out that HILT is, the folks who do the work are us. So conversations come out of these types of meetings, and then we all have to dig in and actually do things that make impact. So we will definitely, HILT captains will come back and talk about what we heard and what some potential opportunities are. But expect to hear from us again and think about what that means in terms of making changes, advocating, joining meetings, making changes in our own institutions. Just thank you all so much. Really appreciate it.
So let me start by saying this. We could not do this without you. You rock. I thank you. And please understand, as Kim has shared with you, we can't do this without you. And this cannot be our first time coming together and we have a conversation and we just walk away. If we do that, we really haven't done anything at all. So I'm asking you to partner with me and the rest of the great people on this call to let's begin to take this journey together. We understand that maybe, hey, you're busy. I got it. I got family, I got kids, I got a teenager, I got all this stuff you have going on. I'm getting a knee fixed in December. But there are little pieces that we all can do. And if we all come and do just our little bit, it becomes an easier lift. And imagine a year from now, when we're having this conversation and we're saying we've got the right people and our pipelines are looking good and our employees are happy and our organizations are healthy and we're taking care of the people that we came to take care of. So thank you for your time. Thank you for joining us. And we hope to see you in the future.
Thank you so much. I am going to have the best night because of that closeout, Kim and DJ3. Thank you. I'm filled with hope and encouragement and excited. Lindsay, Ryan, any final words before 5?
No, this was a great conversation. Again, it's a first step, but again, those issues out on the table, we can all, hopefully have shower thoughts of great solutions or wherever we do our thinking and brainstorming, but looking forward to those connections that'll happen within HILT, but then also seeing some connections that are expanding the reach of HILT into some other networks as well. And that's all works us towards getting that solution.
Thanks, everyone.
Thanks, everyone. Have a good night.
Thank you.
Bye.